Well, hi, everybody. Thanks for joining me, Kevin Stevenson, on I Don't Care with, of course, me, Kevin Stevenson. Appreciate you joining me today. Today's guest is Dr. David Norris. And Dr. Norris has written a couple of books that will be of great help for any physician or any healthcare professional. But first, I want to welcome you, Dr. Norris. Welcome to I Don't Care.
Thank you, sir. It's good to be here.
Good to have you. Hey, tell my audience a little bit about yourself. You know, what type of practice you have, what got you started in writing these books for physicians and others. Just a little bit about you.
Sure. I've been practicing anesthesia for a little over almost 20 years now. Did residency and fellowship at Vanderbilt, went to med school at KU. And then when I got out of residency and fellowship, I joined a practice and then was eventually elected into positions of leadership in that practice, and then was beginning to get handed and become responsible for certain reports and decisions within the group. And with 26 physicians and probably 38, 40 CRNAs. So those are families. So over 70 families, 80 families. Depending on good, solid decisions, I realized I was ill prepared to run a private practice. So I went back and got my MBA while working full time. So I had to go back to class and sit in a real classroom every Saturday for 2 years.
Okay.
And that was quite a shock to the system initially.
I'm sure. And you know, I'm finding so many more physicians going back and getting their MBAs. And so, you know, I think that's incredibly admirable because, I mean, as you and I both know, you guys don't get a lot of business training in medical school.
Nope, get none. And so when I asked about these things in residency or medical school, med school, I was told you'll get it in residency. Residency, I was told, you'll learn it when you get out. And by the time I got out, it was just too late.
Sure.
So what really prompted me to do this was two things. I did a research pay project for in one of my classes in med school or in my MBA program, and I sent out a survey to every physician in my county, and I got about a 35-40% response rate on a one-time snail mail with self-addressed stamp envelope. And in that survey, I asked a bunch of questions. Do you know what it costs to see a patient? Do you know how much you make per patient? Do you know what your expenses are? Do you know how to budget? What areas do you have problems with in terms of leadership, negotiations, patient satisfaction, process improvement, financial reporting, accounting? And then I asked those same questions related to their personal lives. Do you know how much you have in checking? Do you balance your checking account? And I wanted to see if there was a correlation between I don't know what's going on in my business and I don't know what's going on in my private life. Data came back. There wasn't a statistically significant correlation, but there was a strong correlation with those physicians who knew the answers to their business. They also knew the answers to their personal life. And those that did not really have any idea how much they had in checking, pretty much didn't have any idea how much they made per patient. And I remember after I sent that survey out, one of the surgeons I work with said to me, looked over the drapes in one case, and said, I'm not happy with you. And I'm like, what? He was like, your survey made me feel stupid. I'm like, no. Survey. I didn't make you feel anything. I was just asking questions. She's like, well, I didn't like the answers to your questions. I'm like, well, sorry. And that just prompted a discussion, well, there's no real good place to get this sort of stuff without, enrolling in a class. And then I had a mentor that popped into my life about the same time. And he really encouraged me to start writing and doing speaking and consulting work. And those two events led me to start with the manuscript. That was the first book, Financially Intelligent Physician. And the second book is just more about patient satisfaction and how do we design systems that improve patient satisfaction. So that's how I got started, and still working down that path every day.
That's great. Well, let's talk first about the financially intelligent physician. What topics did you did you focus on? And was it a pretty basic book? I mean, what kind of assumptions did you make based upon your survey of your audience for the book?
Yeah, so the survey results, number one, the issue they felt they didn't really know well were financial reporting, accounting. That was the reason why I chose that book first. The second and the third were really kind of negotiations and process improvement. How do we make something better, smoother, faster, easier for everyone? And at the bottom of the list, oddly enough, was leadership, which I've always found curious in that I've known a lot of physicians who think they're good leaders when they're not, but that's a topic for another day. So in the book, I assume that you basically don't have any fund of knowledge, and I pretty much try to walk you through what shows up on these reports. So we start out very basic. I discuss what's on each report, why it's on that report, and what you can expect or should expect to get from an accountant. I cover the P&L or the profit, loss, or income statement. I also then cover balance sheet and then the cash flow statement. And then the next part of the section of the book is really determining the financial health of the product or financial analysis. So we take numbers off those reports, and there are a bunch of different metrics we can use to kind of determine the overall financial health of the practice, much like we do in clinical medicine, where, we hemoglobin A1Cs or PTINR. Same thing with these reports. And then I kind of walk you through all the different ones. I don't cover all the report or all the metrics, but because there are a lot out there. I'd cover the ones that I think you might find useful. And then I kind of suggest pick one and go from there. And then the last part of the book, I talk a little bit about time value of money and how to determine costs, if you don't already know that.
Well, interesting. I've got a lot of friends, obviously, that are practice administrators, and they all say the same thing, that they're incredibly surprised by the overall lack of financial knowledge by their physicians, and so they spend a great deal of time, much as you have done, educating them on the opportunities within the practice, and really shining a light on things like expense control and contracting with managed care providers and whatever. And so I think a lot of that really helps the physicians not only be better stewards of their practice funds and their personal funds, as you said, but also helps them understand how we as hospital administrators have to think about various procedures and things like that in the decisions that we make on a day-to-day basis.
Yeah, Mike, the conversations I had with the hospital CFO after I got through those classes and began to understand, they became much more effective and shorter because we were talking the same language. And whenever he might say something, I'm like, that's not what you mean. Or is that really what you mean? You're trying to pull a fast one on me. And so, yeah. And, if you don't understand those reports or even look at these reports, people will steal from you.
Absolutely.
And so I also say it's a great way to make certain nobody steals from you because we've had a couple of practices here where the office managers have stolen millions of dollars. In fact, one just went to jail. She didn't want to say I'm sorry, right. So the judge gave her time, and she's 70 something. Going to jail.
Gosh. Yeah,
going to jail.
I was going to say it's not only in the office, but certainly on a personal level, because again, so many physicians utilize financial advisors or whatever that they just don't understand maybe the investments that are being made or whatever. And I don't want it to sound like I think all physicians are stupid, but you guys just aren't trained in this way, and so unfortunately, I've had a lot of physician friends who have really been brought into some pretty bad investment deals that have cost them, years of income. And so, I think, you as a physician and someone who did go back to get their MBA, you have a little bit better credibility than most others in speaking with physicians about their financial health. And so I think that's great. So anything else around the financially intelligent physician that you want to hit on before we go to your second book?
Oh, well, I think Of the two, buy that one first, because that one's going to make the most impactful thing, not only in your professional life but personal life. These principles apply both ways. We don't change glasses when we go from when we switch hats. I might have a doctor hat and a dad hat, husband hat, but I usually leave the same glasses on. And how we view the problem is how we view the problem, and all we need to do is change that prescription a little bit, and I think you'll have a happier life, because you actually understand where the money's going to and coming from, and that's really the most important thing. Um, and I find it really frustrating when physicians go, "I don't care. I just want to look at the bottom line." Like that's not how you run a business. Do you think that's how Fortune 500 companies do it? I mean, you might as well act like that, even though you might not be. You can still have uh, good performance if you do.
Yeah, absolutely. Well, and so let's go to your next book, Great Care Every Patient. Tell me about that.
So that book I wrote because I really wanted to talk a little bit about process improvement, and I didn't really used to be kind of an interest or passion of mine, because as an anesthesiologist, I don't really own a lot of those processes. The hospital owns those processes, or the surgery center for the patient, from registration, check-in. I pick it up when they hit the pre-op, and I'm done when they're leaving recovery. But it wasn't until my parents became consumers of healthcare that I really began to appreciate and understand everything the patient goes through. And so I started to try and, in preparation for that, because I think a lot of physicians think they do good stuff, but they don't realize that it's not your perception of your care, it's the patient's perception of your care that
Absolutely.
matters. And I really wanted to kind of bring that argument to bear, and then give them some tools and things to think about as they develop the care in those processes. Because I don't want to say we want to manipulate the patient, but we definitely want to design systems and processes, touch points that reinforce the emotions we want that patient to experience when they go through our clinic. Because they'll remember the emotions more than they will what you tell them, right? You can tell them you have cancer, but or you have a bad disease, or we can manage this. They're not necessarily always going to remember everything you say, but they're definitely going to remember how they feel when they left, whether or not you, the physician, took time and really cared about them, whether your office staff was pleasant. And it even goes from the beginning, like how easy it is to get in. Do they call back to schedule that appointment like they're supposed to, or can they even get the billing right? My dad, he has metastatic prostate cancer, and he likes his oncologist, but when he first started going to him, he wasn't concerned that the oncologist didn't know what he's talking about, but they never could get the bill right. And that said, I don't even know, if he can't get the bill right, is he really giving me good care? Is he really treating me the way, giving me the proper care? And for clinicians, we say, well, those are two totally different things. But for the patient or the consumer, it's all one continuum. And it's that last stop, that last piece of touch point that really solidifies that. If you make a great first impression, you can overcome that. But still, you can still hurt yourself by not making certain that you can get all those pieces in line. So in that book, I just try and give you some ways to think about how to design and really get down on paper the processes, because in the service industry, we have steps that other people own, and it can kind of be hard to conceptualize, to get your brain around all the steps that go on and to getting a patient in the clinic until you get it down on paper. And then we start to assign roles. Who's responsible for this? Are they responsible? And do they have the ability to change if they see a need to change? Do we give that or empower them with that authority? And then we review that and, like, what emotions do we want the patient to feel? And then, go through it as yourself and make certain as a physician. And healthcare providers, a lot of us walk in the back door and we never see the front door. And I've walked through a number of front doors and been like, wow, do they really know what this feels like when they walk in here? You know? And it kind of leaves you scratching your head like, well, I wonder what your satisfaction scores are like. So, those are things that, we just don't really think about, because we think about, well, I'm going to get the diagnosis, I'm going to get the treatment. Boom, that's great care. And it is, but it's not the whole thing. And that's really what that book is trying to illustrate, or trying to drive home, is it's more than your ability to treat the patient. And you have to, if you're going to be in private practice or even in a big organization, you really got to think about every touch point and what you can do to drive the emotional response of that patient, to reinforce that we're here for you, we care for you, we want you to know that, and we're, every step of the way, we want you to be aware that we're attentive to you.
No, I totally agree, and I love how you put that. That we as healthcare professionals walk in the back door, but rarely through the front door. And I think that perspective of walking through the front door, whether it be through the ED or actually the physical front door of the clinic or the hospital, you do get a different view of the entire experience. And I talked to some other folks about physician customer service and all that. Let me throw something out. I'm interested to hear your perspective on it. I think from a primary care standpoint, I want somebody that is very attuned to me, trying to develop that relationship and really make sure that clinic visit goes well. But the higher up I go in medical subspecialties, I'm really looking for that physician who is clinically, excellent. Case in point, I had a procedure done many years ago, not in my current city, but somewhere else. And the physician had a terrible bedside manner, but he was a phenomenal surgeon. And so I overlooked that. What do you think about that?
Well, yes, because you went to him with a certain expectation, certain demands. However, I don't want to excuse that poor bedside behavior. And so part of what I teach DISC, which is a personality style, or for me, it's down and dirty, it's quick, it's easy. But more importantly, after you get to know a patient, you begin to understand their DISC personality. You can begin to talk their language, right? And you can begin to address the patient how they want in their personality style. So I am what we call a high D. So I'm very task driven and outgoing or energetic. Let's get it done. Now that could come across very differently in the 10-minute window I have to interview a patient before anesthesia, depending on your other styles. Now, if you're the style that's complete opposite of me, which is very people oriented and very reserved, I can come across as overbearing. And if I don't understand that, or I don't actually take the time to try and figure out what you might be, based on, behaviors and other things, I might shut you down. I might not get all the information, or I might not really, they might walk away thinking he doesn't really care about me. He's just here to do the job. When in fact, I do want to do a good job, and I want to make certain you get through your surgery. Whereas other patients, and high I, they're going to come to me and they're going to talk. They may not even, they may take 5 minutes to answer a yes, no question. Okay. And if I'm in a hurry and I'm not aware of what I'm thinking and feeling, I may shut that down and say, just answer the question. I don't need to hear about, your gallbladder experience at your sister's wedding in California. I didn't know if you've had surgery before. If I don't tactfully do that, because I recognize that they are a big talker and I just got to let them do it for a minute, acknowledge it, and then move on and redirect, that interview and how they feel when I walk out of that room are going to be completely different. And, there are some patients, or a high C, which is very task oriented and reserved. There's people that come in with their EMR already pre-printed. I mean, they have their entire EMR, right? Those people, I know, as soon as I hear that, I see that, it's like, all right, they're not here for the touchy feely. That's fine. They want to know that I'm going to do a great job, and they want to know exactly what I'm going to do. So then I kind of shift that talk a little bit to address those concerns. And so you kind of tailor it for each patient. And I've just discovered that over the years, I've been using this for about 15 years, and pick a model that works for you and then begin to work on and apply. It takes a lot of effort, but as soon as you begin to really incorporate that, you can address your patients a little differently, and you can still do a good job. I think just because you're a good surgeon doesn't mean that you are licensed to be a jerk on the bedside. And I think, honestly, a lot of surgeons that I know, one-on-one in the OR or, outside the operating room, they are good people and they want to do a good job. They just haven't developed or been taught those soft skills. And I think by really thinking about patient satisfaction and what all the tools that we can use to improve that, I think they could probably even up their game even more. But no, I mean, you're right. A lot of patients do that. They'll overlook bad behavior because of the expert they are, and I think those days are beginning to wane. I mean, we see hospital administrators and nurses and other folks not tolerating outbursts and other such stuff in the OR, even if you are a good surgeon.
Absolutely.
Some things, that pendulum is like, we're not going to tolerate that. And I think, the same thing should be proactively done on the physician side.
No, I totally agree. So you mentioned, it sounds like you're already prepping for that third book on leadership. What direction are you going to take that in?
Well, it's really going to be what I'm doing is I'm taking all of my podcasts, articles that I've written over the course of the last 8 years, and I'm kind of retooling those, recondensing those to hit high points or teaching points, with a number of questions at the end of each section to really, make it sure that you absorb and apply the information. The leadership really is more about, I think, being a good leader goes beyond the title. You actually have to care about the people you work with. And you actually have to realize that other people have lives, and it's not just about you. Particularly as a specialist, I've realized that the hospital's there for the patients. I'm just helping the hospital take care of patients sometimes. So,
okay,
I
look forward to that one too.
So that's kind of what I got the manuscript almost done. It's still being tweaked and stuff, but that's what I've been working on for the last couple months now, is taking all those materials and repurposing them to make them one big book to help residents or newbie physicians or anybody really.
That sounds great. So in our last few minutes, any final words? How can my audience, if they want to, pick up one of your books or maybe engage you in some consulting, how can they contact you?
Yeah, they can reach me at my website, davidnorrismdmba.com, or they can shoot me an email at david@davidnorrismdmba.com. Or they can just give me a call. Number's 316-200-2785. And that's and if they want to buy the book, it's on Amazon and Barnes and Noble. The books are there. They can buy them. I don't sell them myself. I just use the retailer to do that. I found that it was a lot easier. Because I know that they have time to ship the book, and sometimes
sure, I totally understand.
Sometimes I don't, so I just let Amazon and Barnes and Noble handle it. But they can go online and find that as well.
That's great. Well, Dr. David Norris, anesthesiologist, author of 2 fantastic books so far: The Financially Intelligent Physician and Great Care Every Patient. David, thanks again for joining me on I Don't Care today.
Oh, thank you, Kevin. I enjoyed it. It was good to talk to you.
Thanks. Nice to see you, and look forward to having you on after this leadership book comes out.
Yeah, absolutely.
Sounds great. Well, folks, we've just put another episode of I Don't Care in the can. Thanks for joining me, and we will see you next week. Take care.